When I thought about what would be interesting to talk about, I felt like blood work is one where I kind of go over with a lot of the interns and externs that come through. And I think it's very easy to kind of look at a lab and you see which one's highlighted, what's red, what's green, or what have you. But really forget about which individual tests we're really looking at, and what does it mean, and where does it come from. And I think that if you kind of know where they come from, where it means, you might actually kind of remember the disease process more, and also think about why certain things, treatments work and what doesn't. I think that, in a nutshell, I think it might be a really good review for a lot of you guys, but I'm hoping that you'll even pick up some nuggets like, I don't remember that at all. When I thought about blood work, I probably took too big of a bite, because I like, you guys could be here forever, because I was just kind of going through all the different individual, tests on each chemistry, and it was just kind of, oh my gosh, like it's kind of, you could go on and on and on. One area that I decided to take out, because I actually originally had like 30 slides, is going to make you guys fall asleep or just start walking away, because it's sodium. Because sodium is a really tricky one. Sodium is really hard to interpret, I feel. It's kind of it's one of those things that if you're really trying to fall asleep, you can start thinking about sodium, and then you kind of get all confused and you'll fall asleep. So I do want to one day probably touch upon that, because I think those PUPD, what sodium's doing, all that is really important for pathophysiology with a lot of diseases. So that will not be in this presentation today. Let's talk about reference intervals. I do think it's important to remember that it is really instrument and reagent dependent. When you do these biochemical data, it's not a normal distribution. It really is a skewed population. It's not a bell-shaped curve. But overall, you still are looking at 90% of normal sample. What does that include? And that's your interval. It's 90%. So therefore, as a result, 5% of normal animals may have values that fall slightly outside, above or below. Because sometimes I do get vets calling me like, oh, it's like 10 points, 20 points, how far should I go? And I do think that there is some normals that are just outside that. But at the same time, it's a good baseline, and then you have to kind of repeat it and see if it's persistent, and we'll kind of go from there. I also want to stress that when you look at these lab works, they're always adult animals. And sometimes if you do have a young dog, it can be really hard to interpret. Your anemia, it's really not really anemic because it's a young animal. And that's where sometimes you might have to look at a different reference book to see what normal range is. And whenever you have a reference book and what normal range is, it's difficult because really, again, every lab is different. Antech lab, IDEX lab, they're in-house. You cannot use the same reference range. But of course, they're kind of close, But a lot of times when I know our in-house albumin, is low normal is 2.3. But the IDEX is 2.7, so it's always confusing to tell the owner, yeah, your dog is really low in albumin, it's 2.3 or 2.4. And that was my IDEX lab that was sent out. And the owner said, well, it's not no big deal, because I thought the reference range was a little bit lower, and it's not. So you really do have to look at what the reference range is for that lab. Another thing that I think is really, really important is to not get in the habit of just looking at what's normal. Okay, because there are a lot of times where animals could be within their normal reference range, but it's still abnormal. And the perfect thing would be like dehydration. You look at albumin, you're like, oh, within normal range, it's 2.9. But then the animal is super dehydrated, and then once you replace that fluid hydration, you really go down. So I do think that it's really important to don't just look at the color scheme of what's normal, really put the whole picture together. But I do think dehydration is a big one. When you look at the chemistry interpretation, how do you definitely can look at each individual test, but I do find obviously grouping them is really, it's easier, for my mind at least, to think about certain disease processes or organ systems you're looking at. Usually you'll have the liver, then you could have, calcium, phosphorus things, and then maybe the parathyroid, values, and then of course the kidneys. And then the GI. The GI is a little bit tricky because there's really not perfect GI test, but obviously if you have low albumin, you start to have to think through, okay, that could definitely be a GI. But I do want to stress that the GI one is kind of always the one that fools a lot of us because it's normal and the animal's still having a lot of issues and weight loss, and you can have pristine blood work, and those are my inflammatory bowel disease animals. Those are my even cancer, lymphoma. That literally, if it doesn't make sense, if anything, when I see an older animal that's really sick with pristine blood work, I really think of GI disease. That's often a hidden place, or some other kind of neoplastic process that's hidden in the body that may not affect your kidneys or your liver. Again, I think pattern recognition is kind of very helpful. So if that's not how you guys are thinking about the blood work, I think that will make your life much easier. So let's break it down, and we're just going to go down just randomly and talk about different tests within the chemistry. Amylase, I know that's still on a lot of blood work that people send out. I do feel like it's kind of phasing out a little bit more because we just have so many issues with amylase. It's just important that it is in a high concentration within the exocrine pancreatic glandular epithelial cells, but really it is not specific for this tissue. Small intestines, the mucosal epithelial cells have this, and the hepatic epithelial cells have this too. And of course, it has to be cleared by the kidneys. So if you have liver disease, diarrhea, literally your amylase will be elevated. It has nothing to do with the pancreas. And then if you have kidney disease, for sure you're going to have decreased GFR, so you really can't clear the amylase as well. Okay, and there's also probably something to do with the inactivation of the enzyme by itself by the kidneys, and the kidneys not doing a very good job. You're going to have a higher amylase. So it's a breakdown also, not just a clearance. Similar to lipase. You'll see a lot in the exocrine pancreatic glandular epithelial cells, because remember it breaks down long fatty acids of lipids, but it really is restricted to the epithelium. It also is in the adipose tissue and the pancreatic tissue, gastric, and duodenal mucosal epithelial cells. So again, it's not just epithelium, but also the adipose tissue. And there are various different forms of lipases. And then again, you have the same problem similar to amylase. It's a renal clearance, so it'll be elevated. I'm going to be honest, like people when they call me with test results, they're telling me amylase lipase, and I'm just like la la, I'm just thinking it's something else probably, because amylase lipase just doesn't mean anything, especially in the cat, okay? Because it can be high, low, normal, but I do realize if you're dehydrated, a lot of these animals are just coming in sick, and then they're going to have high amylase lipase. Obviously, if it's really significantly elevated and fits pancreatitis, I'm not going to say don't use it. It's just that I kind of want something more. So hepatic disease, it's not released from the actually injured cells, but it's probably the inability to deactivate the pancreatic lipase by the macrophages. So I thought that was kind of interesting. And then remember, lipase will definitely go up with dexamethasone therapy. So you can increase 3 to 5-fold the normal range, and then prednisone will increase 2 to 3-fold. So that just artificially will go up, and that sucks because pancreatitis, with steroids, you have ravenous appetite, like they do get pancreatitis a lot, so how do you sort that out when they're on steroids? So it could be really tricky. So this conundrum of pancreatitis, do we have it or not? I mean, I'm sure you guys are all aware of the SPEC CPL. That's the one that originally came out from Texas A&M, and then ultimately they sold it to the assay to IDEX. And the nice thing about this test, when it was in Texas A&M, they really had a lot of studies where they actually looked at that test and had a high correlation with a histologic confirmed active pancreatitis. And that was like the really nice biopsy too, because really, when you don't, what's your gold standard for pancreatitis? We always suspect it, but it's hard to sometimes confirm. But these were histologic confirmed where it correlated well with the SPEC CPL. It was much better than the amylase lipase, so it is a pancreatic lipase immunoreactivity test. And the sensitivity and specificity, some studies show that it's about 71.7 to 77.8, and then specificity about 80.5 to 88. And the thing about that, you can notice it's not 100%, it's not 100%, I mean, for both of them. Really, we don't have a lot of tests out there that are 100%, but it's not bad. But I don't want to hang your hat too much on the CPL, but it does help me a lot also, because if it's negative, it does, I kind of move on. Maybe there's something else. Then the feline test came out, because the real issue with pancreatitis in cats is that's the one that no one knew how to test for, because we knew amylase lipase was even worse compared to dog comparisons. So they came out with this test, and this test is not bad, but there's various studies on that. But if you notice that sensitivity is like sometimes it could be 67%, but then it's 100% is moderate to severe cases, and then 54% in mild cases. So gosh, 50% of your cases may not be detected. So that could be a little bit tricky. But I guess it's still better than what we have, and this is one of those things that I really put the whole clinical picture, and that's where ultrasound can come in and help me out a little bit. Does it fit from the clinical perspective, the blood work, and the specificity? You know, some people will claim 91%, but then if you look at 100% of, it's 100% in healthy cats, so they won't test positive for that. And then, but then there were 67% were symptomatic cats, but they actually had histologic normal pancreases. So it's not a perfect test. There's another study that came out about 79 to 82, kind of similar to dogs. Maybe not as good, but it's still very close. Of course, that test was so popular, I suspect anti-techs better get on it, because they have to keep up with what's going on. How many people use Antech in this room? Do you know? All right, so that's a good number. I mean, I really like Antech Lab. I was actually at an Antech Lab more before I came to Nashville, and I really liked their pathologists. I just liked their blood work. Everything was really great, but I do felt like, oh wow. The IDEX PLI was just a great deal, because I think it's like $28 for us in the hospital as an add-on to the rest of the blood work. But now Antech, I think it's free for part of their panel, and it really is one that's supposed to compete with the SPEC CPL and the SPEC FPL. When they actually did this method comparison, it was nice that they used Antech Lab to test it, and then they still sent out blood work to Texas A&M, and that's where it was performed for the SPEC CPL and the FPL. And they demonstrated pretty good correlation. Pretty close correlation, but there's a really strong agreement. But if you look at it, again, this population they have to be kind of a little bit more significant. Values greater than 5.3 had a really strong correlation for the cat, and then 91% agree, 0.8% agreement if SPEC CPLs were greater than 400. So when you're actually comparing another test to another test, but then you have to remember what's the gold standard. And even the very first test was like, and now you're kind of farther compared to another one. So I think it can be tricky, and don't overinterpret it. I mean, it's helpful, but you look at the whole picture again. But I do think, obviously, the more severe of a pancreatitis case, the easier it is to diagnose. I think the frustrating ones that I'm sure we've all seen were these mild, I don't know, it could be, but you're not sure. I think that's reasonable to test for it, but just realize you never can rule it out 100%. I do think the mild cases could be trickier. Let's jump to cholesterol. Cholesterol, they're part of the lipoproteins, the high density lipoprotein and the low density lipoprotein. They're really derived from the dietary sources, and then they're synthesized in vivo, mostly in the liver, but it can be in the adrenal glands, intestines, and reproductive organs. I think it's important to remember that when you eat something, it tends to not go up as much, because a lot of people always say, oh, my cholesterol is really high for animals. Eating it can go up a little bit, but not as dramatic as like triglycerides. When we see an increase in cholesterol, I do think I start thinking about endocrinopathies. Most of the diabetes and the hypothyroidism, Cushing's. Okay, those are the big ones. And then there's primary hyperlipidemia. There is such a disease. Remember, the breed is usually the Schnauzer. There's a hyperlipidemia Schnauzer. And then protein-losing nephropathy will have a high cholesterol. And I think that's important, because whenever you have a low albumin, right, I look at the cholesterol. Because how do I know it's not a PLE? PLE, your cholesterol will go down, but your PLNs, the cholesterol goes up. And then you have cholestasis. You definitely want to look at the bilirubin. But remember, not all animals that are cholestatic will have high cholesterol. So you can't rule it out that they're not cholestatic. If it's high, sometimes like severe gallbladder mucoceles and such, they will have high cholesterols. And I do find in cats, however, when their cholesterol goes up, because they don't get hypothyroid, they definitely get diabetes. But the main thing is I don't find the cholesterol being as elevated. When I see an elevated cholesterol in cat, with high ALK phos and such, I do think about cholestasis because they love to get, cholangiohepatitis, that kind of family. The mechanisms for these, we really don't know exactly for the PLN. Some people thought maybe it's the increased VLDL, the very low density lipoprotein production because of the low hypoalbuminemia. And then the other one is they think maybe it's a defective LDL and HDL processing where there's constituents in the plasma that are lost in the urine. Because the glomerulus is too big, the filter holes are so big, you're losing these constituents that normally will help clear out VLDL and then LDLs. And now that you don't have that, they start to become more cholesterol rich. When we see hypothyroidism for the endocrinopathy, why does that go up? And that one is a little bit more multiple areas. So literally, it's a downregulation of LDL receptors in the liver. And then remember, a thyroid hormone 3, the T3, will stimulate LDL receptors and promote cholesterol uptake. So now if you don't have that hormone, literally you'll decrease the LDL receptors. And then therefore you don't have that clearance. Or I'm sorry, decrease LDL uptake. And then diabetes mellitus, it literally is insulin will stimulate lipoprotein lipase, and that is what breaks down the chylomicrons and the VLDLs. When you don't have insulin, that you can have problems. You can see why you're not stimulating the breakdown. And then Cushing's, it's oftentimes increased LDLs. And they think it has to do with a little bit of two things. It's the peripheral insulin resistance that you'll see and downregulation of the LDL receptors in the liver. Okay, so kind of like a little mechanism of the hypothyroidism and then also the insulin resistance, which is kind of like the diabetes mellitus. And then corticosteroids also will stimulate hormone-sensitive lipase, and then they will increase lipolysis and VLDL production. And last, the pancreatitis is when we see the high cholesterol is usually increased cholesterol due to inhibition of lipoprotein lipase. The cholesterol decreases with PLEs, the protein-losing enteropathy. Remember I was telling you how to differentiate PLNs versus PLEs. I really look at the cholesterol, but the other clue is you look at globulin, because both albumin will be low, right, when you lose, we have protein losing nephropathy and enteropathy. Globulin is going to be lost only in the GI. Okay, it's still too big of a molecule to be lost through the glomerulus. So that's another good hint for you. And I also have to stress with PLE, you don't have to have diarrhea, and that's a misconception. If there is diarrhea, it's very clear cut, but a lot of dogs don't. And I do see a lot of cases where the albumin has been low for like 6 months, even before they come to me when they're really having the ascites and such. And so I would never blow off a low albumin. Because especially the Yorkie or these little small breeds that they like to get PLEs. It could be episodic diarrhea to no diarrhea at all. And I feel like the reason is whenever I explain to the client, I just think of like disease processes in the GI tract are like polka dots. So you may just have 1 or 2 polka dots of inflammation or lymphectasia. And then eventually over time you have more and more. So the other normal parts can compensate quite a bit, but eventually if you have so many polka dots that are affected throughout the GI tract, then you really will start to be more clinical. But the initial thing is always albumin. So PLE, after we scope them and diagnose it, I mean, how are you going to monitor? You really have to check albumin. Because that's even if the dog's doing great, because that will give you a clue. It'll go down before the animals are clinical. So liver failure, of course, because it's made by the liver, so therefore you'll see the pattern that I look for is like low BUN, low albumin, and elevated bile acids. But I do have to stress when you have liver failure, you don't have to have all of them. You don't have to have low BUN, low glucose, and a lot of times their cholesterol can even be normal. But bile acids will definitely be the more sensitive marker for liver failure. Cancer, neoplasias, multiple myeloma in cats in particular, if you think about it, the globulins are just so high. I was taught that maybe it's downregulation of the cholesterol, but I think there's other mechanism. But a lot of times the multiple myelomas, remember that's the disease that produces antibodies, right? Globulins. Tons and tons and tons, and it's super, super high. A lot of times when I have one of those cases, what people are going to focus is on, oh my gosh, your albumin is 1.2. And they're thinking they're going to start chasing down the albumin tract. And it's not. It's because it's trying to compensate because it's like the globulins are crazy high. So then therefore the oncotic pressure is not an issue, necessarily. And then the increased inflammatory cytokines can also decrease cholesterol. because you're decreasing hepatic synthesis. As we kind of mentioned earlier, just remember when you eat, you carry the lipid from the gastrointestinal system to the adipose tissue and the skeletal muscle. So lipoprotein lipase, an enzyme that's in the vascular epithelium, will be activated and it will start to break down into fatty acids and glycerol. And cholesterol-rich chylomicrons are remnants. Then the fatty acids and the glycerol are taken back up by the adipose tissue and skeletal muscle and reconverted to triglycerides in long-term storage. Really, we're all talking about, chylomicrons are being made after you eat, or the animal eats. Juice or milky fluid is the word chylo, and micron means small particle. But if you look at the breakdown, majority is all triglyceride. And look how low cholesterol is. It's only 1 to 3. I think it's really important when you see serum like this, people always think, oh, that's really high cholesterol, I bet. It's actually not. This will be a high triglyceride animal. So if you run blood work, your cholesterol will be totally normal. So this is, so a lot of times, after eating, you're going to have that lipemic look. There are certain diseases that kind of affect triglycerides and cholesterol differently. So if you see high cholesterol without high triglycerides, I think of PLN, hypothyroidism, and cholestasis. But if you have high triglyceride and high cholesterol, then you're doing diabetes, Cushing's, and pancreatitis. Not all labs will have the triglyceride, but that's something that can be helpful. I mean, the nice thing about all of this, though, it's kind of a moot point because you're going to still be able to diagnose diabetes mellitus, Cushing's and all that. But just to think about that, how lipemic that serum is and such, that's why these diseases you're going to often have lipemic samples versus this type you may not. So now we're going to talk about liver enzymes, okay? Obviously, in animals, when they form stones, they don't get like the stones that we get. They kind of get more cholesterol stones. I don't know if you guys ever seen when we open a cat that's like, we see the choleliths on radiographs are blocked. Literally, when we open them up, they almost remind me like kind of like Play-Doh, that kind of texture. It's not like hard like a calcium or that type of mineral. It literally is almost like a thick Play-Doh kind of texture. And that's why it's kind of tricky because they don't always show up on radiographs too. They're not always mineralized per se. So let's talk about liver enzymes. So ALP. So remember there are 2 isoenzymes. And what are isoenzymes? Remember they're products from the 2 different genes. And then each gene will actually have this post-translational modification and that's called an isoform. When you think about these 2 types of genes, there's really intestinal ALP isoforms, and there's ALP. That's a steroid-induced ALP. Okay, and remember, it's only in dogs, not in cats. So whenever we see the high ALP-phos, it just must be the animal's on steroids. But that's a dog thing, and it shouldn't be happening in a cat. So you have to start looking further. It's a cat. And then it's interesting because ALP is induced by corticosteroids, endogenous or exogenous, but the product is from an intestinal gene, but it's actually produced in the hepatocytes and not the intestinal epithelium. And then the other isoenzyme is the tissue nonspecific ALP isoenzymes. And so the isoforms are the liver one, ALP, B as in bone, ALP, and the placental, and leukocytes. Actually, leukocytes have a lot of ALP in it. It's not really clinical for us, though, because I know that like in histopaths, they can like kind of look for certain markers. If there's like a certain leukemia, it's not even a leukemia, I guess. Like eosinophils have high, the pathologist will look for ALP-phos staining type of thing within the white blood cell, but really not practical for the clinical setting. So in general, just remember that the ALP is an inducible enzyme, so drugs can really stimulate that and induce that release of the enzyme. The common drugs are steroids, phenobarbital, nutraceuticals. So I do want to say that when owners will say, hey, I bought this on the internet, there's all these like stuff now. I mean, it can affect your blood work. So sometimes you will have to kind of look. There's actually, you could like Google nutraceuticals and ALP. There's a nice little table that has like all the things, because half the time, and I'm looking at these ingredients they bring me, I have no idea. Is it like a recipe of something? I have no idea what it is. But sometimes if I am chasing an ALP or something, I kind of say, hey, get off on all these supplements, and we can start to see where we go from there. There's a lot. The lag phase of 24 hours to several days is when they can get induced, but it really depends on the level of cholestasis. And the half-life is about 2 to 3 days for both the liver ALK-Phos and the the steroid-induced ALK-Phos in dogs. And it's only 6 hours in cats. And so I do think it's important because the lower concentration, actually ALP is lower in concentrations in cats. It also has a very short half-life compared to the dog. So if you ever see an ALK-Phos kind of high, it's probably significant. You might want to look into it more. Versus dogs, how many ALK-Phos are high? There's so many of them. You could chase it, it's no big deal. There's so many other things that can cause it. Increases with cholestasis, of course, the bioaccumulation in the hepatocytes will stimulate ALP release. Remember that ALP will actually increase before bilirubin, so it's a really good sensitive marker for cholestasis, and even if it's only a small portion of the liver is affected. For bone, really, obviously, remember the growing dog will have a high ALK-Phos, usually 3 to 15 months, and bone lesions. And what's interesting, though, osteosarcoma, you would think they would have a high ALK-Phos, but most of them don't. Okay, I threw it in there because that's what people always think, because it makes sense, but for a reason it's not. But they did do a analysis where they actually looked at ALK-Phos, and they found that like ALK-Phos greater than 120 had a negative prognostic indicator for osteosarcoma, because most of the time they're normal, but I don't know how to make too much of it, but in either case I thought that was interesting. The ALK-Phos expression is normally restricted to the canicular membrane of the hepatocytes, but can also be induced secondary to cholestasis, and also obviously steroids. And when the steroids induce it, it's on the sinusoidal membrane. This is the part you're like, what? Because I don't remember, all this like canicular, what is it, sinusoids? I always have to refresh that whole histopath, because I do think, I don't know if you guys ever take liver biopsy. I really love Sharon Center. She's the Cornell guru for the liver. She kind of reminds me of like The Beautiful Mind, but liver, and she probably sees these patterns and stuff all day. But the main thing is she does great reports, really, really detailed. And I think it helps because when you do histopath readings for the liver, it is so hard, especially if you don't have a good sample. I kind of sidetracked a little bit, but just to refresh your memory. So remember that there are these little hexagon shape, that's how it's set up, these little lobules. And in a microscopic level, you have the liver cells, and then you have the portal vein coming in from the intestines, and then eventually it flows to the liver, right? And then ultimately it goes this direction to eventually go up to the central vein, because now during this whole procedure you're cleaning out, filtering out stuff, and then eventually it'll get distributed to the heart. Then you have the bile system, the biliary, that actually ducts itself. This is a nice picture of the biliary duct. But then you have these little bile cananiculi, so these are the tiny little tracts along here. So when we talk about cananiculi, these are the little cananiculi, right? The little channel that are throughout the liver that's going this like these little green things, diving in. And then on that cell, that liver cell, is toward that green thing, that's, the caninicular surface. As opposed to the sinusoidal side, that's where you hit the vessels, because that's blood, right? And then that's where that side induces what we're talking about, sinusoidal versus caninicular. And I think this helps because, like portal, what's that microvascular dysplasia, and especially when you start reading her reports, like she really kind of dives into these like different anatomy, and then you don't remember, and then this is a nice refresher, because a lot of times like the vessels, when you have a shunt, they're just not they're poorly developed in this area where it kind of disappears. We have ALK-Phos that you can be. Chronic endogenous corticosteroid release is chronic stress, and again, dogs only. You'll see the ALK-Phos increase, and it initially actually starts with the liver ALP, but then eventually the C ALP will come later on, several days later. So you can imagine chronic stress, and there's so many illnesses that are just chronic; they're just not well regulated. Sometimes that's where the ALK-Phos is coming from. Chronic diabetics, but so many illnesses, and therefore, if I have a dog that is having a high ALK-Phos, but there's a lot of inflammatory issues going on, it's not surprising, especially if it's chronic. And if you look at how long it takes to kind of induce that steroid induce, up to 10 days, and sometimes that's why there's it kind of accumulates over time, and then your ALP kind of goes higher and higher over time, and it could be in the system for so long because it takes a while to induce. And then this is just kind of weird facts for elk phos. Sometimes if you have a young Iberian Husky, they just have a really high, crazy elk phos. You're thinking, oh gosh, it must just be a puppy, but it's even going beyond what you expect for a puppy. The key thing is that it's really not exciting because doesn't have any clinical issues. So you don't have to think about, this dog to have Cushing's or something weird, with high elk phos. It's literally, or cholestatic, and it's mostly bone isoform. And then, so it's pretty rare. And then the Scottish Terriers, that one we do see a lot. A long time ago, I think there was maybe 2000 or 2002, there was we call it Scotty hepatopathy, we called it, And then there's some papers saying, hey, if you take out all these normal Scotties, they also have higher elk phoses in general, and they're not even Cushingoid. But this is also the population that are predisposed to Cushing's. We felt like maybe the reference range for a Scotty should be different. It should be higher. Then a more recent study that ultimately looked at all these Scotties, and they just think it's actually just all subclinical hyperadrenal corticism, so they don't require any treatment, but their ALP phos will be quite high. And it's all due to the steroid-induced, the CALP. And remember, I'm pretty sure Antec does this too, but you can test. If I have a high ALP phos, I'm like, how much is it steroid induced? I will send out a CIALP. You could do that, and they'll break it down for you. If it's 90% of it's all CIALP, I'm like, all right, this is a steroid induced. This is not something that is primary liver. So I think in the IDEX it's called CIALP, corticosteroid induced ALP phos. That's how the name of the test. The Scotty, the CALP, and the Siberian Husky. GGT. GGT is a really sensitive marker in cats in particular with biliary tract disease. It's also great for dogs too. What's interesting is in cats, if you have a really primary inflammatory disease that actually involves the pancreas or the liver or the gallbladder, the GGT activity will go up, and it'll be much higher than the level of ALP phos. I think this is a really nice way to differentiate if you just have a fatty liver disease, that's primary fatty liver disease, versus something, pancreatitis fatty liver disease, cholangiohepatitis fatty liver disease. Because obviously anytime a cat goes off food for a long time, they're sick, they get secondary fatty liver disease. But there is that population that's just primary. So those are the ones that often will have a very high ALP phos, but then you run their GGT and it's normal. That doesn't fit pancreatitis, it doesn't fit cholangiohepatitis, it really probably is primary. Both of them require E-tubes, of course, to feed them through the fatty liver, but it's a little bit different prognosis, because hey, I could get you out of this primary because I just need to give you food. As opposed to, chronic pancreatitis, you're going to become a diabetic, then you're going to go through the cycle over and over again, potentially. Just a little bit more intense, there's more antibiotic involvement. I do think it could be helpful to sort those two out. And sometimes you just can't, but it could be very helpful. And then the GGT, there are small amounts in the canonicular surface and the sinusoidal surfaces of the hepatocytes. ALT, I remember as a student, I think I've said this before in another lecture, as a student I always had a hard time remembering which one were cholestatic, which ones is leakage, and I remember L means leakage, and the P looks like a gallbladder to me. And the G stands for gallbladder, so if you're having issues. So the major source of it is in the cytoplasm hepatocytes for ALT. AST is also in hepatocytes in the mitochondria. It's very liver specific in regards to ALT, but not AST, because that's skeletal muscle too. So when you have a situation where your AST is high, I don't know if it's all from the liver or not, I look at CK, because I know that's purely skeletal muscle, or muscle, versus liver. The magnitude increase crudely reflects the number of affected hepatocytes, so obviously super high ALTs, it's obviously more troublesome than mild elevations. And the half-life is about 2.5 days, but AST is a much shorter half-life. It can take several weeks to decrease after acute insult. So typically if I have a case, I don't track it every day or once a week, I kind of wait a few weeks. But because it's a relatively short half-life. Sometimes you're hoping that you're heading the right direction. And I do it weekly to every 3 weeks or 4 weeks. And I do feel that if it's like twice normal or so, that's when I really look into it more. But again, it's a trend if it's something that's kind of creeping up slowly. There are other sources of ALT, that's the kidney disease, heart, and skeletal muscles, and the pancreas, but those are just really minor. Bilirubin. Bilirubin is a great liver function test, really. It's to see the ability of the hepatocytes to take up unconjugated bilirubin into blood and conjugate it. And when it does, it makes it more water soluble, and then excrete it in the bilirubin into bile, where it's broken down in the intestines by bacteria. I do have to say that in reality, we really use this not for a liver function test. The main liver function tests we typically use are really bile acids, and then we also will do ammonia here, but it's just really, really sensitive for ammonia, that if it's normal, I can't prove that there's good function for ammonia, but if it's high, it definitely, if you have that encephalopathic animal, you're trying to sort out why. Sometimes ammonia definitely can be a little bit high, but bile acids can definitely be the more common function test. So we tend to use it in general to sort out, is this liver or hemolytic anemia? I think that's really the big one. If it's liver disease, obviously with or without cholestasis, because if you have liver failure and it's not cholestatic, your bilirubin may still be high, but then obviously if you are cholestatic, then for sure your bilirubin is going to be high. So I always look at red blood cell level when I have a high bilirubin. And remember that if your bilirubin is high, you can't run bile acids, because that's another thing I see sometimes. I don't know why, because remember, I don't know why people do it, because you have to realize that if you're cholestatic, you can't differentiate. If your bilirubin is high, it could be cholestatic or liver failure. Both bile acids will be high. However, if my bilirubin is normal and my bile acids is high, it can be decreased function or early cholestasis. Because remember, bile acid is more sensitive for cholestasis. So it could be tricky. And that's when I look at the ALP-phos, because maybe it's really high. Maybe cholesterol is starting to get high. And obviously, I have the benefit of really looking at the ultrasound to see how's my biliary ducts, the common ducts, intrahepatic ducts, are they all kind of getting really full or congested. So remember, bilirubin, it has to be greater than 1.5 to kind of start to visually see the pigment. And it stays there for quite a while. So if I do have an animal that is quite icteric, even though the animal's getting better, the owners still get nervous because they're still so yellow, because once it kind of stains the skin, it's just hard to get out, but eventually it will go down. There is the breakdown of bilirubin of unconjugated, which is indirect. So this is the albumin bound, and it's dominant form of the total bilirubin in blood. So it's produced in macrophages from the breakdown of the red blood cells, and it makes it water insoluble. But in plasma, it is albumin bound, so it makes it more water soluble. Some labs will definitely give you the indirect and direct. Conjugated is the water soluble one. There's very, very small amounts in the blood because it's really excreted into the bile. This is a form that is actually in urine. So when you see bilirubin in the urine, that's what's conjugated. And dogs are the only species that can have a little bit of bilirubin in their urine normally when it's super concentrated. For any other, like cats, you should never see bilirubin. We're kind of taught, it depends what university you went to for vet school, but a lot of people do the pre-hepatic, hepatic, and post-hepatic, kind of like pre-renal, renal, and post-renal. Some people like this method. I think it works pretty easily, but I realize that the hepatic could be kind of tricky with post-hepatic because you're still within the liver anatomically, kind of. But either case, I think it's still useful to kind of group your ideas together, where your pre-hepatic hyperbilirubinemia is always the red blood cells. It's being lysed. It's the increased production of the bilirubin from breakdown of the heme proteins. And so unconjugated is going to be much, much greater than conjugated. And I do find it interesting that a lot of animals that really have primary IMHA, they are truly cholestatic too. So it's not, we don't know the mechanism. So there is truly cholestasis. They thought maybe there's hypoxic injury to the hepatocytes, and then the ATP depletion, decreasing the excretion of the conjugated bilirubin by the transporters in the canonicular side of the hepatocytes. So if you think about it, some people think of it as like a funnel where you have so much unconjugated bilirubin because it's all coming from the broken red blood cells, and then the end of the funnel is this really thin area where the conjugated bilirubin has to leave, and it keeps getting narrow, more and more narrow. So you truly you're just overwhelmed with all that unconjugated, and you have to get processed. So that's where there's truly cholestasis. So that makes it so difficult because sometimes, I'm sure we've all been there, where you're like, your bilirubin's super high, but it doesn't match the level of anemia, that you have, and those are because there probably is primary cholestasis. Then you have the hepatic hyperbilirubinemia. And this is defective conjugation or uptake of the bilirubin by hepatocytes. So either you can't conjugate it or you just can't uptake it. But it also includes the decreased excretion into the biliary canaliculi. So that's a structural issue. And then there's also a functional defect, which I'll go in there next. When it comes down to if you can't process this in the liver, it really has to do with transporters. And then you can't conjugate, maybe you don't have enough conjugation compounds in the liver because the liver is so diseased it just can't even conjugate it because it doesn't have the ingredients to conjugate it. And then what's functional cholestasis? So you don't always have to have the gigantic gallbladder with a stone or pancreas. Literally there is a functional cholestasis, and that is actually one that people forget all the time. When you have the high bilirubin and really severe inflammatory disease, it's because there's decreased bile flow due to cytokine-mediated downregulation or inhibition of transporter responsible for excreting the bile salts or conjugated bilirubin into the bile. So you don't have to have a physical obstruction. This is an inflammatory process, okay, because of the cytokine mediated. The big one is E. coli. So sometimes we see a lot, especially in the cat. So we do think other species will have the same issue, but at least there's a study that actually proved that there was a dog with dogs that E. coli definitely will cause this functional cholestasis. And then so you have a really high total bilirubin, and then you suddenly look at the liver enzymes, and actually they're just mildly increased, and the ALK-Phos is even normal. Because most of the time you think high bilirubin cholestasis, you got to think of high ALK-Phos because it looks like a little gallbladder, but it's totally normal. So just kind of review of when you have biliary tract within the liver, here's your gallbladder, and then it just really kind of goes throughout the whole liver. So sometimes they will just have one little area, and this demo was just more like tumors, but really it could be anything. Inflammation that's kind of stricturing down, scar tissue, little tiny plugs that can form and be clogged up into this bile system. Then you have the post-hepatic hyperbilirubinemia. This is where it's extrahepatic, so they're technically outside the liver, and it affects biliary flow within the gallbladder, bile duct, or biliary papilla in the duodenum. So this is a time when your conjugated bilirubin is much greater than unconjugated. We're usually talking about this area. Okay, so remember the common bile duct? Then remember that in particular the cat, they share the same opening, right? So then that's why they love to get cholestasis when they have pancreatitis. So really anywhere outside the liver, this whole area can be obstructed, and that's extrahepatic. We do see a lot of tumors right there, and they're tiny. They're almost like the size of a nickel or a dime. When I do an ultrasound on these guys, it's like super tortuous common bile duct, and then even sometimes the cystic duct is all crazy. And then I can't find the actual mass. It's not one big thing. So if I have a really cholestatic animal, it's like I have to go to surgery. And unfortunately, a lot of times in surgery, they're going to tell me it's a tumor. And sometimes you can't see it, but when you feel it, it's like this hard little tiny pebble or something very, very small. And it's just a bad location because it's just totally blocking it. It's usually a carcinoma commonly. But that one's hard to diagnose because for without surgery and ultrasound, you're thinking cholangiohepatitis and all the other common ones. So we've seen that both in dogs and cats. And then pancreatic tumors is another big one. If anything, if I do an ultrasound and I see a chunky, almost like mass-like lesion in the pancreas, but yet the dog doesn't present like pancreatitis, but yet you have an ugly pancreas, I get very nervous about those cases. Because if I run a pancreatitis test, like a PLI, it's totally normal. And that's actually when I start thinking about tumor. There's a pancreatic tumor, so they're not actually having pancreatitis, but they're just blocked. But eventually they can get pancreatitis because it really blocks even the enzymes from getting out to the duodenum. Let's talk about plasma proteins now. plasma proteins are albumin, fibrinogen, and globulins. Usually when you see the total solids or plasma proteins to be less than 4.0, you really probably need some kind of support of colloid fluid to really maintain oncotic pressure and normal tension. So we tend to use head-of-starch. We often will, especially for that PLE dog for me, when they have a lot of severe effusion, albumin is like 1. And I'm about to anesthetize because I really need to get my GI biopsies. And why do I need to get GI biopsies? It's because I got to sort out is it lymphangiectasia or inflammatory bowel disease, because that's totally different prognosis, different, a little bit different treatment, similar but different too. So that's why I still like to try to scope these guys if I can, and and sometimes I will give canine albumin transfusion. We used to use human albumin transfusions, but now we have canine, and I like it because it's canine, because sometimes you will have reactions to the human albumin, but it's pretty cool if you ever use albumins, because literally you can have that really tight belly, because you can't just draw it out, because if you draw it out it just kind of fills right back up. They get really dehydrated, and they literally could disappear in 24, 48 hours sometimes. It's like it just sucks right back into the blood vessels. So it's really rewarding. But that's why you really always have to check blood pressure, because just because can you maintain normal pressure is going to be really important. You often will have to decrease drugs that really are highly protein bound. It doesn't take much of a propofol, because we frequently use a propofol to induce. And if you have a really low albumin animal that's going to go into anesthesia, we just don't. It's amazing how little they need. And remember, when you're using the refractometer, plasma will have fibrinogen in it. But versus a chemistry panel, it's run on serum, so that's, remember, lack of fibrinogen, because you removed it during the clot formation. Okay, so your total protein is going to be higher in plasma versus serum. I also want you to, when you guys do that refractometer, sometimes you'll have these crazy high numbers, and wondering why. There are other solids, technically in the serum, where the sodium and the chloride and the phosphate, glucose, cholesterol, urea, those are all things that can really affect that. Lipemia will also be a big one to falsely increase results. And then if you have hemolysis, you just have that blurry line that you can't really focus on the line or looking on a refractometer. It's really important that when you have this type of serum, it can be really tricky to really get an accurate total solid. Albumin, it's 30 to 50% of plasma proteins, and it really provides 80% of the plasma oncotic pressure. It's really made by the liver, but remember, you have to lose greater than 80% of the liver function to actually start to see that decrease. So it's really not a great sensitive liver function test, because you have to be pretty bad off before your albumin starts going down. So again, bile acids is the way to go if you have this suspicion of chronic active hepatitis or chronic hepatitis when albumin is still normal. And low albumin, again, liver's insufficiency, increased inflammatory proteins and acute phase proteins, and I think that's one that we often will forget, because we often are eager to look, why are you losing albumin, but sometimes it's actually low because all the other proteins are really high, the acute phase proteins. And of course we talked about the PLNs and the PLEs, and then the other big one is vasculitis. You don't have to have the peripheral vasculitis. I've had some weird ones where dog albumin is low. Of course, we did the urine, the UPC, urine protein creatinine ratio is totally normal. It's not a GI. Globulins are totally fine. And then I do an ultrasound, and literally there's like fluid in there, and I don't know why. And then they'll even have bicavitary where there's pleural effusion. And most of the time when I see a bicavitary effusion, I think of neoplasia. Sometimes they're like middle-aged, 5-year-old dog, So sometimes vasculitis can be like immune mediated, where they start to seep out, and that's where your albumin's going. And then, of course, pancreatitis is a big one for vasculitis that we're probably all more familiar with, but sometimes we do get that weird vasculitis that's primary. We don't know why. And those are the other one is that their albumin will be like 1.7. I have a dog in the hospital right now, it's 1.7, but yet it has effusion. So we know it's not due to oncotic, because it's not low enough, because albumin has to be like 1.2 or less for it to be effusing. And of course, blood loss and burns and decreased dietary intake. The decreased dietary intake, that's like owners will always tell me, oh, the albumin's low because he skipped, he hasn't been eating well for the past week or two. You really have to be in a pretty bad starving state for your albumin to go down. So I think that's pretty rare, except for the really caucasic animal that really has been a poor doer for so long. But most of the time when I see something like that, it's probably intestinal loss, more so than I haven't had food for weeks. Sometimes the reduction in albumin, it just maybe allows for greater increase in the amount of amino acids available for the positive acute phase protein. That's one of the theories where you're shifting your amino acids. It's not going to make albumin, it's going to make something else. And then again, look at globulin and cholesterol and the level of anemia to help kind of group them into where it's going to be. Is it a PLN? Is it a PLE? Is it liver disease or blood loss? So what are the acute phase proteins? Proteins that change serum concentration by greater than 25% in response to inflammatory cytokines. They really mediate the systemic effects of fever, leukocytosis, increased cortisol, decreased thyroxine, and decreased serum iron. So these are big players of the acute phase protein. And again, you're not measuring it. That's the tricky part. So I think a lot of times we look at the low albumin, forget there's acute phase proteins that can be really high up that we're not truly measuring, and the animal's really sick, and we're going down the PLE or the PLN track, but this is actually an animal septic or something else that's going on. The interesting thing that you'll see is I remember thyroxine really decreases. And so many times I see thyroid panels being run on really sick animals. And probably that's not the time to run a thyroid because you're going to be low. And a lot of times you just do a total T4. If you probably ran a thyroid total T4 on all our ICU patients right now, probably like 80-90% will be pretty low. They all look like hypothyroid. And remember, hypothyroid do not present like this really sick animal. So that's not the time to kind of look for that. So remember again, the acute phase proteins are just part of the innate immune response that have antibacterial effects, and they can be measured by electrophoresis, but actually there's specific assays that you could actually request that's a little bit more sensitive. So you can look for C-reactive proteins. If you kind of break it down, there's positive acute phase proteins. That's a C-reactive protein that a lot of people measure. Serum amyloid A, heptoglobulin, and then several other ones. But I'm going to be honest, I rarely run them because I think there's so much inflammation that's going on in the body. I think it's just something that you just have to remember that this is a process that's going on versus I'm going to try to diagnose your illness because it's not specific. It just is an inflammatory response. Don't forget that there's negative acute phase protein, and albumin's that big one. Okay, so that's why the albumin will be low. But there's also transferrin, and sorry, typo, and then several other ones. If this kind of sounds familiar, the serum amyloid A, do you guys remember what serum amyloid A, what disease back in the days? Yeah. So amyloidosis, remember what breed? Chinese, so Sharpei's. Okay, so ultimately, remember, Sharpei fever is the one that's excessive serum amyloid A, so it's an inflammatory response, and then they deposit in the tissue, and that's where they get amyloidosis and such. They get kidney, liver, spleen, pancreas, adrenal glands, thyroid, GI tract, lymph nodes, and it really causes a lot of organ damage. And that's where you're supposed to use colchicine to kind of impair that release of serum amyloid A. But remember, you're supposed to impair it from the release from the hepatocytes. But remember, you want to do that before azotemia because that's where they all kind of crunk out because the protein-losing nephropathy gets really bad. By the time they're in renal failure, it's too late to add colchicine then. So a lot of times people will do it when you have 2 episodes of fever and joint swelling, and then it's like probably good to start. Because sometimes they just have one and you're done, but that's something to think about. So minerals, really just calcium and phosphorus stuff, balance. And the maintenance and function of muscle cells is really what the main thing for calcium. But it does help a lot of enzymes. It helps with blood coagulation, and it does inorganic transfer of ions across cell membranes. And remember, it's artificially low in hypoalbuminemia because calcium is 35 to 45% of the calcium is bound. And mostly it's all to albumin, 80% of it. So you really need that ionized calcium to help you know what's going on. And then you can do that calculation, but this is kind of like, no one really does that as much anymore. There's too much, you can't rely on this. It's really better to just kind of do an ionized calcium. But that is kind of the formulation that kind of gives you some idea if you want to do that corrected, but I just feel like don't rely on this formulation because sometimes it can fool you, especially when you look like it corrects normal, but your ionized is really off. Remember that the ionized calcium is a metabolically active form of calcium, and that's what your body senses, right, and responds to. So it's absorbed through the intestines, and mostly the ileum, and it's mediated by vitamin D, and PTH indirectly promotes absorption to help convert vitamin D to active form of calcitriol. So absorption of calcium is inhibited by corticosteroids, and the steroids promote renal excretion. So that's why whenever you have a hypercalcemia animal, you can use steroids because, again, it helps that process of decreased absorption, and then also helps with excretion. And calcium, of course, is mostly in the bone, 99%, and PTH is main regulator. So the PTH stimulates osteoblasts to secrete factors to promote osteoclasts to develop from monocytes. That's about 50 to 55% total for the ionized calcium. And again, it's the active form. It's protein bound, about 35 to 45% of the total. Most of the protein bound calcium is bound to albumin, though, so that's the key. The rest is to globulins. And there's also this one group that's just a complex anions: bicarbonate, citrate, phosphates, and lactate. I did my residency at Ohio State, and we were hard ions. I know there's another one out there. Do you guys know what the other one is?
Hogs and yarn.
Hogs and yarn, yeah, yarn. Yarn? Yard, okay, all right. So I know there's so many different acronyms that you can remember. I don't know, I remember hard ions. Yeah, it's really good that we have the idiopathic, I guess. But the hyperparathyroid is the big one, and Addison's is the other one, and then the renal disease, vitamin D toxicosis, and the idiopathic. Then osteolysis, and that's really rare, okay? But sometimes we will see that multiple myeloma and the neoplasia. I do want to say that if you look at, if I want to kind of go over some notes here that I took that may be interesting. Addison's, not all of them are hypercalcemic, okay? And it literally is about 38 to 45%. And the reason why this happens is steroids enhance absorption and excretion of calcium. So now without it, we just talked about that. That's why when you give pred to a hypercalcemic animal, it does help with lymphoma, but it also does it other way to bring down that calcium. Vitamin D toxicosis, I think the one that we see the most is like usually anti-psoriasis cream. I have a lot of dogs, and then we don't know why they're hypercalcemic, and you ask the owner, is there any medication in the house that's a cream for psoriasis? And sometimes a lot of times that's where your answer is. That is one big one. The other one that I thought was kind of interesting is granulomatous. Do you guys know why granulomatous disease is part of vitamin D? Because macrophages make vitamin D. So remember, granulomatous inflammation means macrophages, right? So that's where they get converted, and they actually produce vitamin D. Because I couldn't remember what the mechanism was. Because I remember if you see a fungal infection, sometimes that will be hypercalcemic. And because they're macrophages, do you remember what kind of cancer macrophages become or can be? Because remember lymphoma, lymphocytes. Yes, so histiocytic sarcomas, they can also be hypercalcemic, in rare cases. So if I remember certain mechanism of action, I kind of remember which tumors too. And then the other one with lymphocytes, how do they cause hypercalcemia? It also produces vitamin D. It's not just a PTHRP thing, but it's actually a vitamin D. Neoplasia is a broad term. I know when I was going through school, I remember they're just focusing on the PTHRP. So I used to run it for all my hypercalcemic animals, and I'll do the PTH and the PTHRP, and I don't even remember, maybe one time out of like hundreds that I would say that it was positive. I was the majority. I don't know how you guys feel about PTHRP, but I don't think it's very common to be as elevated. However, it still could be neoplastic. It doesn't have to be driven by PTHRP, but it's actually driven by the tumor secreting vitamin D, like that histiocytic sarcoma, lymphomas. The tumors also secrete vitamin D or osteoclastic cytokines.
Is this list for both dogs and cats?
It technically is more dogs, but it is cats too. But cats, it's very rare to get Addison's. Yeah. But I think everything, the cats are the idiopathic. That's a big one. So I think it's a combo, But I do feel definitely in neoplasia in dogs, you'll see the hypercalcemia more so than in cats. But multiple myeloma, sometimes. So the neoplasia, the key point was that the other key thing is that phosphate is often frequently normal when the calcium is high. Calcium is high, phosphorus should be low, right? Because you're always trying to do that calcium-phosphorus balance. But phosphate is actually normal and can even be decreased in hypercalcemia due to PTHrP. That's what I was trying to say. And then the lymphoid, the lymphoma, do you remember which cell line tends to be the calcium-secreting ones, or the ones that causes hypercalcemia?
T cells.
Yep, that's right. So the T cell origin. And sometimes, I know Dr. Vansel likes to kind of sort out T or B, sometimes a little bit prognostic, certain drugs too, that tend to work a little bit better on T versus B. Then, of course, what's the other big one is adenocarcinoma, the anal sac adenocarcinomas. And then there are some various other ones like thymomas. Thymoma is like 34% of the 116 cases in one study. And then and we talked about histiocytic sarcoma already. What happens when you have hypercalcemia? I think it's really important to remember the severity of clinical signs. It does not always depend on the severity of the hypercalcemia. It's more the speed of development. So signs are more severe if they're rapid onset of hypercalcemia, and the ones I think of is really like lymphoma cancer, as opposed to the slow developing hypercalcemia of the same magnitude. So you have two dogs, one has super high calcium, the other one's super high calcium, but one is caused by cancer, it really spiked up really quickly. What's the other disease that would cause really hypercalcemia chronically, long time, so therefore their signs are not that bad? The big one is hyperparathyroidism. So I'll see a dog like, hey, calcium's super high, and I look back, it's been going on for a long time, and the dog just looks too darn good. I feel like most of my lymphoma ones, it's like, oh, they could, their kidneys are not happy, just things are just kind of tough. But I do think that it's slow onset, they can do pretty well. And that's probably why, like hyperparathyroidism, sometimes like owners don't come to the vet for a long time. They're just not that bad. They make their PUPD, but they're just not as sick. So why are they so PUPD? So remember, hypercalcemia will cause nephrogenic diabetes insipidus. So it inhibits ADH response and reducing the medullary tonicity by decreasing sodium chloride absorption in the loop of Henle. So also decreasing the permeability of the collecting ducts to urea, enhancing renal medullary blood flow. So that's your PUPD mechanism. Then if you kind of constantly have this, you'll have the renal tubular damage, because remember it decreases GFR. And then how does it do that? Because it's the renal vasoconstriction. Okay, then it causes renal ischemia, and then you have these renal tubular dysfunction. So this is why you really want to treat a hypercalcemic animal long term, because it's not great for your kidneys, aside from just a PUPD. And the higher the calcium goes, it gets scary because that number goes up really high. Remember, when you get soft tissue mineralization is when it's greater than 60. When we see a hypercalcemic animal, we think, did it cause a renal failure? But remember, renal failure can also cause hypercalcemia, so which one came first? So on the muscular system, there's a decreased excitability of the skeletal muscle and generalized weakness. I find that fascinating because I had a case, I remember, hyperparathyroid. I diagnosed it. Owner just couldn't afford surgery because it's such a nice disease. You just pluck it out and get out and be done. And then she didn't come back to me for like 2.5 years. I was like so surprised. And she came down, the dog came in on emergency being down. So I found it fascinating. This was it looks like a down dog. And literally it was just hypercalcemia for so long. It really affected the more muscular system. And then literally just so weak that he looks like a back dog. And then once we removed it, the hyperparathyroid, calcium corrected, like the dog got strength back. It was just pretty amazing. And then ileus and constipation from decreased contractility of smooth muscles, and hypercalcemia can also stimulate gastrin and acid secretion, so you could cause vomiting and ulceration. So hypercalcemia is not bad. I had to put them on some acid reducers like proton pump inhibitors. Yeah, I'm sure you guys know the proton pump inhibitors can always be better than an H2 blocker. And then before, people said don't cut omeprazole, but you totally can cut it now. There was a reason at the last ACVIM. There's several nice studies that really show that you can cut it and it's not going to be a big deal. And then the other thing that was really cool was really it changes acid. It really, omeprazole really increases the pH significantly when you do a BID. because usually that's taught once a day, versus famotidine or H2 blockers or twice a day. But if you have an ulceration, I think the last JAVMA article, journal, had a nice case about the dog wasn't getting better and it was ulcerated, and ultimately they did a BID dosing and it made a big difference. They actually did a little measurement in the pH and made a significant difference. Nervous system, it can, again, that dog that I was telling you about, the hypercalcemia, was really weak, so it was also neurologic kind of, so therefore it can also cause severe paresis. So who knows, the muscle, the nerves, everything combined. Cardiovascular system, it really doesn't do much. Okay, so that's more like, hey, that's interesting, you hook up an EKG, you might see some arrhythmias, but it's pretty rare. The big arrhythmias are the potassium family, but calcium is like, it doesn't do much. But you can see a prolonged PR in a shortened QT interval. Renal secondary hyperparathyroidism, that's thought really due to low vitamin D, and it's a tubule disease, and it decreases the absorption of filtered calcidiol or vitamin D binding proteins, and then you see hyperphosphatemia because of decreased vitamin D synthesis. But again, I don't know. I know that was totally crammed into me because I don't know. Dennis Chu, the internist, that's really into calcium, and I feel like it's definitely great information. But I don't know how practical. I don't usually run. But I do. Obviously, I want to. And every time I have a calcium issue, I have to run PTH to sort out what's the cause, low or high, just to sort it out. And then sometimes you can't get that renal secondary hyperparathyroidism. So that's where you have decreased ionized calcium, and it's because of the hyperphosphatemia, or decreased absorption of calcium, and it stimulates PTH, which causes osteolysis in an attempt to maintain ionized calcium values, and that's why you get that rubber jaw. Again, we see so many renal disease, I don't really get the rubber jaw very common. I think it's one of those textbooks that you're like, oh, that's interesting, but it's just not as common as you think. Total calcium values may be normal or increased due to anion complexing. Remember I was talking about the complex calcium with the phosphates and the citrates. And the key point is that the ionized calcium really cannot be predicted. If you ever see these high calcium animals, you just don't know, is it going to be really truly decreased ionized or not? So sometimes you're really concerned to see what you need to do. The ionized is easy to try to measure. Then now let's talk about hypocalcemia. So that's the renal loss. It's often lack of PTH, resistance to PTH, or inability for tubules to reabsorb calcium. And then calcitonin also causes increased loss of calcium in the renal tubules. So why would calcitonin be up? We see that in pancreatitis. Also ethylene glycol toxicity. And then there's many different mechanisms, but that's one main one for pancreatitis. But you also see calcium going low because remember the saponification in the pancreas, and you go to surgery, you see those little calcium deposits, and you'll see that. And then with ethylene glycol, you'll also see the precipitation of calcium by oxalate, one of the metabolites. And then for pancreatitis, it's also postulated that it's due to glucagon release from the inflamed pancreas, and then glucagon is what stimulates the calcitonin release. Several different studies. I know there's one for a dog. There's definitely this one I pulled for the cat. That's relatively more recent. It's low calcium is a negative prognostic indicator. So when you have that really bad pancreatitis test and how are you doing, when do we let this cat go, these are sometimes I will use blood work to kind of help guide me and guide the owner where we're at. But it is the serum ionized calcium is a negative prognostic indicator for pancreatitis in cats. Another one that we forget about is actually protein-losing enteropathy, and you could get severe hypocalcemia and hypomagnesemia, but it's reported in dogs. But a lot of times we've seen it in Yorkies, but really you usually don't see signs of hypocalcemia. I know some people want to supplement and such, or they're in the hospital, but they're not always symptomatic. And I think that once you focus on fixing the gut, everything absorbs, just like your B12, just everything. It's all related to the ileum. I do want to also mention the primary hypoparathyroidism. That's the other big one I see. This one is interesting because it's actually, I wouldn't say it's just such a cool disease, because when we see it, there's some funky things that you don't see in other diseases. And that's that stiff gait, and they're itchy. they'll start to rub their face on the carpet. They look like, you know how dogs after they take a bath or so, they would like go around. I mean, they'll kind of be, they look like allergy dogs or something. And I've had a few of them, and they're all hypoparathyroidism. And it's a great, easy diagnosis. Do your PTH, appropriately low, and then boom, calcitriol is the treatment, right? Forever. But I remember that owner telling me, yeah, he does walk kind of funny. That was an orthopedic issue forever. And that's why that owner was not happy, because she felt like it was always blowing off as arthritis, weird gait, and then lo and behold, the calcium. Because sometimes the full panel's not run and calcium may be missed, and that's like one of those weird, funky ones that would be kind of cool to just go, boom, your dog has hypoparathyroidism. They do look weird. And they're not always consistent, all their clinical signs all at once. It could be gradual. And then they definitely could have like seizures or tetany. And we run into this a lot when we do the hyperparathyroid surgery. So when you guys are referring us a hyperparathyroid dog, from a medicine standpoint, we always want to start on calcitriol about 1 week prior to start to upregulate things, because even it doesn't make sense because my calcium's high. Why would I want to add more calcium? Because when you're about to pluck out that parathyroid, it's going to drop really quickly. So that I do find that if you have about a week worth of calcitriol, they just go so much smoother for the recovery. Because sometimes they just can't go home because they're in tetany or what have you post-operatively. So you'll see us checking calcium quite a bit after hyperparathyroid surgery. And usually it's compounded, so you have to kind of have all this. And remember, it's in nanograms. So it's like a very tiny amount, so it's kind of weird because a lot of times the pharmacist will kind of not put in the right units, and it's very little. And then other causes, eclampsia, small breed dogs, 2 to 3 weeks post-whelping, and then sepsis is another big one, and that's a big one to help about prognostic indicator. It's a really high risk factor for mortality. And then you could cause a lot of nerve, muscle, and heart dysfunction. And then phosphorus, really, this is kind of nothing really too exciting. I've found calcium in general, that's kind of the bigger one, but the hyperphosphatemia, you just want to see it in dehydration, decreased GFR, that's probably the biggest thing. And then you're super dehydrated, your phosphorus goes up, and your calcium is up, and again, calcium phosphorus product can be a big problem because they'll start to mineralize. And then potassium, remember it's a major intracellular cation for muscle and heart, so that's the one that causes all the arrhythmias and such. Hypercalcemia was seen with metabolic acidosis, Addison's, lower urinary tract obstructions, anuric renal failure, so these are all pretty straightforward when you see a high potassium. And remember the arrhythmias, like when you're seeing greater than 8 millimoles per liter, is really life-threatening. Quite honestly, if it's a black cat, then you can get that down pretty quickly. Addison's, we give the DOCP injection pretty quickly, and even if you're in a situation where you can't get that cortisol level back, we're very lucky because IDEX is next door. We just give it to them, we get that result. But if you can't, giving DOCP in a hyperkalemic animal is not going to hurt them. If you're thinking, oh, this is Addison's, I'm going to pull my sample, but I don't wait till tomorrow to get my results, it's not wrong, Fluid therapy is also going to obviously help a lot. And then hypokalemia, the low ones, the biggest one we see is DKA. We see that a lot because a lot of times they'll be normal coming in, but you forget once you start insulin therapy and their sugars are crazy high, it's going to go right into the cell and they go drop pretty low. So even if I have a normal potassium in a DKA, you're seeing me minimally putting in 30 milliequivalents per liter. But a lot of times it's going to be 60, 80, sometimes crazy. And remember that 0.5 milliequivalents per liter per hour is when you could get into that's dangerous, but it's really hard to get that high, because you have to memorize what that super high toxic level is. But again, that's pretty hard. I think that is. Any questions or any of the comments? Well, thank you so much for coming. So for sure.